Okay, I think we're live. So welcome to Tamarah's Closet today. I have the most special guest today. I am so excited because he's like a rock star of a different sort. And it's just such an honor to have him here today. He is a neurosurgeon at Wake Forest Baptist Medical Center, but he's also my neurosurgeon, and he is a professor of surgical sciences and neurosurgery. And he's here today to talk. We're going to talk a little bit about the gamma knife and brain tumors. And he actually treated me last year with the gamma knife about a year ago. And I tell you, this man has so many accomplishments, it's really hard to know where to begin, because much less pronounce everything that he's done. So you'll have to bear with me today pronouncing all these big words. But he graduated from Cornell University Medical College, but he did his postdoctoral training at Harvard Medical School. He is the co-director of the Gamma Knife Unit at Wake Forest, as well as the co-director of the Deep Brain Stimulator program. He is also the medical director of Neurological Oncology at Wake. He actually established and led the Wake Forest Gamma Knife Unit to consistently be one of the 5 busiest gamma knife units in the United States. And he also established and led the Wake Forest Deep Brain Stimulator program to be among the busiest in the world, implanting over 1,000 deep brain stimulators, representing more than 0.5% of the worldwide total. So I'll have him talk about that a little later too, because I did want to know about that. Wake is also the home to the first gamma knife in North Carolina. And so I'm going to have him be talking about the gamma knife, which I believe is the stereotactic radiosurgery. And their team is among the most experienced in the country. They have the Lexcel Gamma Knife Perfection Machine, which is the most accurate and most advanced radiosurgery technology available. So without further delay, I want to introduce to you Dr. Stephen B. Tatter. Can you say hello, Steve, so I can know you're with me?
Hello, Tamarah. Thanks for having me.
Oh, I'm so excited to have you here. Not many people want to meet a brain surgeon under the circumstances that I did.
Exactly. But people would much rather meet a rock star.
Well, you are a rock star. I tell you, after I was going over your bio, you were such a superstar. I had no idea. So it just made me feel more blessed to have fallen into your hands when I did find out I had the brain tumor. So that's just been a blessing for me, for sure. But I know, Dr. Tatter, that you established and led Wake Forest to become the most active gamma knife centers and the most experienced team. So that does make you kind of a rock star. What was the motivation behind all this, for you to accomplish all this? Do you ever sleep? I don't know how you did all this.
Oh, I'm a really good sleeper. Sleeping and eating are some of the best things that I do, in fact.
Well, what was the motivation behind it all?
Well, there were things that weren't available to folks in North Carolina, and they were things that I was very interested in doing, and radiosurgery is one of those, and deep brain stimulators is another one. And when the CV, my curriculum vitae, is where you got a lot of that information. And it's supposed to be sort of bragging, I think, but I'm a little uncomfortable. I'm from the Midwest, so I get a little nervous when I hear the list of accomplishments. I mean, they're really things that you do to help other people, and that's really the motivation for it. It's kind of funny when you go to interview for medical school. They know, why do you want to be a doctor? Well, because I want to help other people, and they get tired of hearing that. And I say, no, but that's really the truth. That's what I want to do. And I think that all of those things are a team effort. And the way we really like to think about it is that way, that there's no one person, it's not me who's done any of this by myself. And that we really want to think that that all the doctors in the world are a team, and that our patients are the owners of the team. And I think that's a lot better way of thinking about it than the stuff I sent you on my CV.
Yeah, but you do have a passion, then a strong passion for helping people, obviously. So that's,
Yeah, it's very rewarding. Exactly. It's probably not on a day-to-day basis. It may not be as much fun as being a rock star, but it's very rewarding.
But I did see something on there that I thought was, and I know you're being modest, but I saw that you were the first in the world to implant that gliocyte brachytherapy, I guess, in a human. I don't know if I pronounced it right, but
yeah. And it's interesting with medical terms, pretty much any pronunciation is actually correct, because as you go from one part of the country to another, or one country to another, they pronounce them differently. So people feel like the way they pronounce it is right, but it turns out that's often not the case. Usually we happen to say brachytherapy instead of brachytherapy, but I'm sure somewhere they say brachytherapy. It's as right as brachytherapy. But it's a way of delivering radiation from inside the tumor out, and the gamma knife is a way of delivering gamma rays, which are a kind of radiation, from outside of the tumor in. But we sometimes the tumors are, one of the limitations for gamma knife, I should say, is the size of the tumor. And if the tumor is too big, then gamma knife isn't a good option. Delivering the radiation from outside to in isn't a good option. But instead, going in and taking most of the tumor out, and if there are microscopic cells left behind, delivering radiation from inside where the tumor was to outside is another way of treating tumors.
Okay, but that one is for, that treatment is for the recurring malignant tumors, is that right? Or
exactly. And so we use it for metastases, tumors like lung cancer, if they've gone to the brain. If they're smaller, we would treat them with gamma knife. But when they're large, we would take it out and then put this device in that delivers radiation from inside the tumor. And then a few days later, we would be done with that device and be able to take it out. While the gamma knife, we don't have to go into the head at all. The gamma ray beams are going in there, but there's no incision or anything for gamma knife. So we prefer gamma knife when it's an option over this brachytherapy.
Okay. Well, I know I wanted to ask you a little bit about, before we get into the gamma knife, I wanted to ask you a little bit about when you decided to go to med school, because this has always fascinated me. I don't know why, but since I was a kid, I was fascinated with, if you'd see these shows on TV, and it was about a doctor, I always thought if I were to be a doctor, I'd want to be a brain surgeon, because I just thought that would be the most exciting field to specialize in. So I was wondering, when you decided that you wanted to go to medical school, did you know you wanted to specialize as a neurosurgeon, or why did you, I can't believe I'm asking this, but why did you pick the brain? That sounds funny. No pun intended. But.
No. The whole process is an interesting one. And no, I didn't have any idea that I wanted to be a neurosurgeon when I started medical school. And my interest in medicine was a little different probably than the average person's, but I was really interested in science in general. And I thought, oh, well, what better place to apply science than to people? And so when I went to medical school, I think I probably thought I would specialize in infectious disease or oncology, maybe medical oncology rather than surgery. But then during the third year of medical school, you go around and you rotate on different specialties. And I just really loved surgery. And it had to do with, I think a lot of it was the way that you spend your time. When you do surgery, you're really just focusing on one thing for a number of hours often. And you get to just totally concentrate on doing the very best job that you can do for someone, versus in a lot of what we would call the medical specialties, as opposed to the surgical specialties, there are a lot of demands on you. You're checking labs on this person and then writing orders on this person, and you can't ever say, oh no, I'm in the operating room, I can't address that issue right now. But when you're a surgeon, people understand when you're in the operating room, that's what you're focused on. And which is kind of a funny reason, but in the end, it's how you spend your day that I think it's got to be something that you like doing every minute of the day. And so surgery fit the bill there. And then of the different specialties in surgery, certainly the brain is a really, I'm biased of course, but it's a really interesting thing. You know, I'm sure some people think the liver is really interesting, or the lungs or the kidneys, but the brain makes us who we are, and there's so much that's not known about it that we're finding out and contributing. Usually small things, but in some areas, you know, really contributing things to understanding how the brain works. And even when we're not doing that, we're certainly learning about it all the time. So it's an area where you never run out of things to learn. Yeah.
Well, I just think it's fascinating. So then you just narrowed it down like into the third year or something? Is that
exactly.
When you, yeah. Okay.
And I did a PhD while I was in medical school. So my third year was about 7 years in. I tell people I was in a remedial medical school program because it took me longer, but it wasn't really remedial. It was because I was doing research in virology, actually. And we deliver viruses into the brain to treat brain tumors and to treat Parkinson's disease. None of those treatments are approved, so they're on clinical trials rather than treatments that are available for everyone. But I participated in clinical trials in things that I also did research in for my Doctor of Philosophy degree.
Oh, okay. And that was in virology, you said?
Yeah, studying viruses.
Viruses. Okay. Wow. That is fascinating, though. But now I wanted to ask you, because you're with Wake Forest and Baptist, and for anybody that's watching, if they don't know, this is a teaching hospital. What are the advantages of being on the faculty of a teaching hospital to you as a surgeon, but also what are the advantages to the patient?
So I think the big thing about a teaching hospital that you could also, in general, most of them, and certainly Wake Forest, think of it as a research hospital.
Research.
So it's not a hospital where we're doing an experiment on every person who comes in to get treated, and a lot of our treatments are standard treatments that could be available at a non-teaching hospital or a non-research hospital. But some of the things we're doing would only be available at a research hospital, like the viruses into the brain that I was talking about. But then we're also, so for example, we've written 2 papers about all of the people with meningiomas in their brain who we've treated with Gamma Knife. And what are the results? What are the things that predict that someone might have complications? So we're studying what we do as we do it. And when we do a lot of something, since we happen to have the busiest Gamma Knives in the country, we've often done among the most of something like treating meningiomas. So when we're describing what's happening to hundreds of people with meningiomas over time, other people who've done fewer than that can take advantage of our experience. And I think that's a little bit rambling.
No, that's.
but that it really is the opportunity to learn from our experience and to use it as a basis to improve what we're doing and to improve what other people are doing.
Right. But isn't that advantageous to the patient because you are doing more research than a typical hospital?
Absolutely. And it makes it so that we're doing things that aren't available elsewhere. So sometimes the standard treatment would be the best treatment for someone. But for some things, our standard treatments aren't very good. And the opportunity to participate in an experimental treatment could be very advantageous for them. gamma knife, interestingly, North Carolina has a law called a Certificate of Need law, and they don't want too many gamma knives in the state because they cost about $6 million. And one of the reasons that Wake Forest had a gamma knife was because when we applied for the Certificate of Need, we said that we would do research. And in fact, for example, in the past academic year, our group published more than 16 papers on our experience treating different kinds of things with the gamma knife in the peer-reviewed medical literature and journals like the Journal of Neurosurgery, not things that you can buy at the local bookstore. But
right. Well, what is the are you still? I know you're a professor there. Is teaching a big part of your passion as well?
Yes, and the way that you learn to be a neurosurgeon is, you could think of it as an apprenticeship, that you do a residency, and that the residency is hierarchically organized so that there are first-year residents all the way, it's a 7-year residency. So you start out not knowing how to do much. You learn some things as a medical student, and then as you go along, you're able to do more and more, and the opportunity to work really closely. So there are only 9 neurosurgical faculty at Wake Forest, and we have about the same number of residents. So we get to work really closely with our residents. We also get to work closely with medical students, not as closely the residents. We're working with them for 7 years. And with the medical students, they often rotate on the service for a month, or sometimes they'll come back and do a second month. But it's a little bit less intense. But the same idea that we're learning really a lot from what we're doing, from sharing our experience and working together. We try really hard to make sure that never works to a patient's disadvantage. If you went back to the olden days, I think there was probably a time where, and people still worry about this, you'll go to a teaching hospital and, oh, a medical student's going to take care of me. But now you would see, well, that's not really what happens. There might be a medical student there learning. There might or might not be a resident participating in the case. But in the end, the attending, the professor, is going to be there for all the important parts for the whole operation, for example, and really doing the most important parts of the operation. And so you don't get less of the professor, you just get more people on your team. And a lot of times that's very helpful to patients to have a team. It gives them more access, faster to get their questions answered. If they need something in the middle of the night, well, the resident is called a resident because they're there in the middle of the night. So while the attending gets to be at home in the middle of the night. So it's really nice if something came up, a resident could just walk right over and see someone right away, while an attending, if they needed to, could get in their car and drive to the hospital and see them. But the fact that we have residents makes them much more accessible to people.
Okay.
Advantages.
Okay, I wondered how that worked, because I know. So do you actually take a group of students around, or residents, to actually each patient, or? Sometimes
we do that in the intensive care unit nowadays. Okay. Is the way we do it. Neurosurgery is sort of a lone wolf specialty, though. We don't tend to go around as a group the way some other specialties do, and it just has to do with efficiency. We more everyone's working on things all the time, and so to have 2 people doing the same thing is usually, we don't have that level of staffing to have that amount of redundancy. But on the weekends, for example, we go around in the intensive care unit together as a group, and the students are there, the residents are there, and the faculty are there.
Okay, because I know a lot of people wonder about that, because we see these things on TV and it's not always the same as what you're seeing on like Dr. House.
Yeah, we sure try to make things, that idea that all these doctors and residents and medical students and physicists are members of a team and that the patient is the owner of the team, that they're all working to the advantage of the patient. And some of that's behind the scenes. Most of the stuff that you see at houses and conferences and things like that, I think, where they're not directly interacting with the patient, but people are interacting with one another, and we certainly do a lot of that. So we have a Gamma Knife conference every week where we talk about everyone who we're going to treat, and then we have a brain tumor conference every week too, where we talk about people mainly who we've already treated.
Okay, all right. Well, now I had seen an interview of you, and I think it was actually a few years old. So at that time, you said you'd treated over, I think, 3,000 patients with the Gamma Knife. Do you know what it is to this date, or?
We're just over 4,900 now, so we're not quite to 5,000, but we're almost 5,000.
Wow. That's a lot. Well, before we go into, I wanted you to talk about just the different brain tumors, but first I wanted you just to sort of explain what the Gamma Knife is, because I know a lot of people don't know.
Of course not. And the big thing is it's not a knife. And so I think they came up with the name actually in the 50s, I think, was when they came up with the name, just because they thought it sounded cool. And to a certain extent it does. It's a device, though, that takes 192 gamma ray beams, and they come from all around in a cylinder, and they're actually just holes drilled in the cylinder, and they intersect in a little tiny sphere. So you have 4 millimeter spheres, 8 millimeter spheres, and 16 millimeter spheres. And they intersect at the center of this cylinder. It's a stainless steel cylinder that weighs 22 tons, actually. And that's so it's mainly shielding, so the gamma rays aren't going anyplace else except where we target them. And the targeting precision of the Gamma Knife is about the thickness of a coated sheet of paper. 0.3 of a millimeter is the accuracy with which those beams are delivered. Now, if you were to take a scalpel and try and cut on a line, you wouldn't be able to stay on a line 0.3 of a millimeter thick. So the Gamma Knife is more precise than a knife, but it's not cutting anything. It's just delivering gamma rays with that precision that you would get with a knife. What the gamma rays do is a little bit complicated, and I love to talk about it if you think
that's fine.
People would be interested. But
yeah,
but it actually, all radiation, both its beneficial and its harmful effects, are mediated the same way. But it causes a chemical reaction in DNA. So every cell has 2 strands of DNA in it, and the 2 strands of DNA are just held together by positive and negative charges. And so, but they're really weak, but it's like a magnet on a refrigerator. So for a tumor to grow, the cells have to divide. For the cells to divide, they have to separate those 2 DNA strands. And it's, again, as easy as taking a magnet off a refrigerator for the cell to do that. If you give the right dose of gamma rays, which hopefully we always do, you get a chemical reaction on each of the 2 strands. And so those 2 chemical reactions interact with one another and form a new kind of a bond. It's called a covalent bond. That covalent bond is millions of times stronger than the chemical bond, than the electrostatic bonds that normally hold the DNA together. And so those covalent bonds, the cell can't break them. It's like taking that magnet and welding it to the refrigerator. So now, if the cell tries to divide, it can't, because it can't separate the DNA strands to make a copy of them. So then the daughter cells don't get a copy of the DNA, and both of them die. And that's really the way gamma rays, or radiation in general, works. Now, Gamma Knife is different than radiation in general, mainly because it's so highly focused. That radiation is, the regular radiation, just you don't have that 0.3 of a millimeter accuracy. You might have 3 or 4 millimeter accuracy, or sometimes a little bit better than that, but it's not delivered as precisely. So to make up for that, what happens as a result of that is more normal tissue would get treated with radiation, with conventional radiation. And so to make up for it, you divide the treatment up into multiple doses. Turns out the tumor cells aren't as good at repairing the injury that the radiation causes as the normal cells. And so the damage, the 2 hits that you have to get that covalent bond, is the way I like to think about it, is much more likely in the tumor cells, because the normal cells repaired 1 hit in between the doses of radiation. Again, the gamma knife doesn't work that way. The gamma knife, all the selectivity is based on targeting. And so it's just targeted very precisely. And that's why we can do it in just a single treatment. And so the generic name for it, as you mentioned, is stereotactic radiosurgery. And the radiosurgery refers to the fact that we do it in general as a single treatment. And in fact, when we do it as multiple treatments, which is unusual, that sometimes we do that, we don't call it radiosurgery anymore. We call it, have all these long names, as you also mentioned, but it's hypofractionated stereotactic radiotherapy if you were to divide it up into, say, 4 treatments instead of 1 treatment. But usually gamma knife is a single treatment.
Okay, and it's just more focused. But the regular radiation can make you cause the side effects, right?
Yeah, so for example, if you got regular radiation for a meningioma, one would lose their hair, which for some people would be really bad because they have really nice hair. And for others of us, wouldn't be as big a deal. But so it's really nice because the dose to the skin with gamma knife is in general less than 192nd of the dose that the tumor is getting. So it's not enough to cause you to lose hair as a rule. Versus fractionated radiation, again, there's a much higher dose to the normal tissue. And so you end up losing your hair from fractionated radiation.
Right. Yeah. Well, yeah, I like the whole not losing the hair part.
Exactly.
Well, what are the different types of brain tumors that you treat and that you see? And what else can be treated with the gamma knife? Yeah,
so there are a number of different kinds of brain tumors. We often divide them up into what we'd call primary brain tumors, tumors that start out in the brain, and secondary brain tumors, tumors that come from elsewhere to the brain. So meningiomas are the most frequent primary brain tumor that we treat with the gamma knife. The most frequent tumor that we treat are actually secondary brain tumors. Again, metastases would be another name for those. The most frequent kind of metastasis is lung cancer that goes to the brain. And we can treat, some people with lung cancer might have 4 or 5 tumors in the brain or even more. And we can treat each one separately because there's not an interaction between the different targets because they're so highly focused. So there's little interaction between multiple metastases, for example. There are kinds of primary brain tumors that we don't treat with the gamma knife, and the most frequent example of those are called gliomas, and that's because they spread in the brain. A lot of brain tumors don't. Metastases don't tend to. They tend to stay in one place. Meningiomas certainly, as a rule, don't spread anywhere other than just where we can see them on the MRI scan. So the gamma knife is really good for tumors that don't spread around in the brain, because with the gamma knife, a limitation of it is we're only treating what we can see on a scan. If it's too small to be seen, if there are microscopic cells someplace, then we're not targeting those with the gamma knife at all.
Right. Well, when you say it metastasizes to the brain from the lung, it's from the lungs. What?
It could be from any tumor. It could be melanoma, a skin tumor. It could be from the kidneys. It could be breast cancer.
But it just moves, you mean, or
yeah,
what?
They go in the bloodstream usually, and then some tumors have a propensity to set up shop in the brain when they're spreading around in the bloodstream, and others don't. Some almost never go to the brain, like prostate cancer never goes to the brain, but most others will at least sometimes go to the brain.
Right.
And then other kinds of tumors we treat are other, what we would call low-grade tumors, or sometimes we might call them benign tumors. So the most frequent ones are meningiomas. The second most frequent ones are called schwannomas, but the most frequent of those is one of the balance nerve called a vestibular schwannoma. But the balance nerve is also the hearing nerve, so we usually call it by an older name, an acoustic neuroma. But that's a tumor of the hearing and balance nerve. That behaves a lot like a meningioma. Meningioma is a growth of a lining around the brain, and a schwannoma is a growth of cells that make the insulation around nerve fibers in nerves that are inside the skull. and that's the second most frequent kind of tumor that we treat with the Gamma knife. Our primary brain tumor are schwannomas. And once in a while, we'll treat gliomas under certain specific circumstances. We treat tumors that are called glomus tumors. And we also treat things that aren't tumors at all. The Gamma knife was really developed to treat tremor, interestingly. There's an overactive area in the brain that causes tremor. And you could fire in these 192 gamma ray beams into this little 4mm sphere and just kill that overactive area in the brain. And we still do that sometimes. There are other ways we treat tremor now, for example. One of the most frequent things we treat with the Gamma knife is a really painful condition of the face. It's called trigeminal neuralgia. The trigeminal nerve is the sensory nerve that comes from the face. And
I was going to ask you about that. Explain what that is.
And it's a pretty rare thing, although I've seen several thousand people with it over the years, but you would probably never have met someone with it. But I've seen several thousand people. One, because Gamma knife is a good treatment, and we have only 1 or 2 Gamma knives now in North Carolina, and for a long time we had the only one. And second, because I'm so old, I've seen a lot of folks with it. But it's the most painful condition as far as we know that people get, and it's like a seizure in the nerve, an epileptic fit in the nerve, where the nerve is just firing off as hard as it can, producing the most intense pain that I think that we could imagine. And then the way a seizure works and the way this trigeminal neuralgia works, the nerve runs out of energy. It can't keep firing that intensely for very long. So it's intermittent, really intense intermittent pain. The trigeminal nerve is called that because it has 3 branches, one to the jaw, one to the cheek, and one up to the eye and the forehead. And it can affect any or all 3 of those branches. And it's usually caused by an artery pressing on the nerve. And that's one of the things we do is regular surgery, where we go in, make an incision behind the ear, and look in and with a microscope, and then move that artery off the nerve. And we actually then wrap the nerve with this thing that looks like a little cotton ball. It's made out of Teflon fibers. That operation is called a microvascular decompression. But it's a pretty big operation. The Gamma knife we think of as being non-invasive. And the microvascular decompression is the opposite of that. It's a very invasive operation that takes people weeks to recover from. Well, with the Gamma knife, we often say, oh, have brain surgery today. There was a billboard that the Gamma knife in Phoenix used to have up that said, have brain surgery today, play golf tomorrow. But with the microvascular decompression surgery, you can't do that. No golf the day after microvascular decompression surgery, as a rule. And I hope that many people feel like they can really get back to their normal activities quite quickly after Gamma knife. That's one of the goals of it.
Well, can you treat the trigeminal neuralgia in one treatment of the Gamma knife? Or
yes, exactly. Now, the disadvantage of Gamma knife for that trigeminal neuralgia is the treatment isn't permanent. So the gamma rays, what they're doing is just damaging the nerve. And as I mentioned, the normal cells aren't as sensitive to radiation as tumor cells. So we actually give almost twice the dose of radiation of gamma rays to the trigeminal nerve that we would to a tumor. And it's actually almost 4 times the dose we would give to treat a meningioma. Meningiomas are very sensitive to gamma rays, and so we don't have to give a really high dose, but we give a much higher dose to the normal. But despite that, over a period of about 5 years, the nerve will repair the damage that the gamma rays did, and the trigeminal neuralgia will come back. And then we can do it again. So it's only intended to be a single treatment, but we know over a period of years that it'll often end up being multiple treatments.
Well, yeah, go ahead.
No, I'm sorry, I didn't mean to interrupt. But usually trigeminal neuralgia is more frequent as people get older. And so people in their 70s and 80s usually choose Gamma knife, which is most of the people with trigeminal neuralgia. But I've treated people who were even children who had it. And of course, for them, that operation where we go in and move the artery, since that one's usually permanent, is the better option.
Wow. Well, how is the Gamma knife? Well, it obviously is changing things for patients with brain tumors, but how in terms of like recovery, as far as, I'm trying to think how to ask this, is the outcome of their illness or that you're treating, is it like if it's a serious tumor that is the long-term, I guess, the long-term recovery or the cure, I guess.
Yes. And so there are two categories of folks who are treated with the gamma knife. One are people where we don't really have another good option for them, and the gamma knife is just the best. It's the most likely to cure them, would be one way of thinking about it often, but it's also the most likely to give them a good quality of life for as long as possible. A lot of the kinds of tumors that we treat aren't benign or low grade, but are serious or malignant tumors. And not that benign tumors aren't serious, though, because a meningioma is a serious tumor if you're the one who has it, for example. But if you have a cancerous tumor, sometimes we're not going to cure it, and sometimes we are. But even when we're not going to cure it, we still want to do the very best that medicine can do for someone, to give them the best quality of life that they can possibly have. Or even more importantly, really in a lot of ways, we think it's to help them achieve their goals. It goes back to that thing about being the team owner. We can't always get the outcome we want for people. I wish we could. And a lot of times we can make a tumor in some ways like it wasn't there. But overall, sometimes with the disease that someone has, we can't do that. And that in the end, a person may very often die of the disease that I'm treating them for. But what we can always do is respect them as a person, respect their autonomy, respect their ability to make decisions for themselves, and to tell us what's important to them so that we can do the best that medicine can possibly do to get as much of that as can possibly be available for them. And I think that gamma knife has changed things in that way. So say if you went back 20 years ago, if someone came in and they had 10 metastases from melanoma to their brain, you'd say, well, we're really sorry, we're not going to do 10 operations probably, that would make your quality of life really bad if we tried to do that. With gamma knife, you come in, get all 10 treated, go home the same day. So, and we actually have a very high success rate at treating those tumors. It's more than 90% chance that each of those 10 tumors is going to go away after the gamma knife, or what we really describe it as is local control. It's never going to cause a problem. It's never going to grow in a way that causes a problem. So we took an untreatable disease and made it treatable. And that's a big category. I think a lot of the things we treat, we could treat with open surgery, but the quality of life that someone has is often better with gamma knife. So that's more a choice, someone's preference, that they would say, oh yeah, I could go have this tumor out, but then I'd have to recover from the surgery. I'd get a bad haircut out of the deal, and it would hurt. And gamma knife, the shots to numb up, I think, hurt. I'm not very tough, so I tell everyone, oh, there's this one part that's going to hurt, but then after that, we hope nothing hurts. But with surgery, you're sore for a long time after recovering. Brain surgery, not as bad as other surgeries, fortunately, because we don't have muscles other than the ones we wiggle our ears with, but they're not very big muscles up around most of our head. And so people tend to not have a lot of pain from those surgeries, but still it's recovery, it's risks that we don't have with the gamma knife often.
Right. Well, when is the gamma knife absolutely not an option, like for a patient? I guess with a brain tumor, maybe, or
yeah, and so the gamma knife isn't something that's without risks, and the big risk, or a way to think about the big risk, is that a tumor sometimes can die too quickly, and then the body can't absorb the dead tumor. So you've got this dead thing that's causing swelling, usually is the problem, or putting pressure on the normal brain. And then you have to go in and take that out. So the goal of gamma knife was to avoid regular surgery, but in the end, you had to have it anyway. And the chance of that happening is a function of the size of the tumor. So really big tumors, often gamma knife's not an option for them. Sometimes we can treat them by dividing the gamma radiation up into multiple doses and getting probably more selectivity between the normal and the brain and the brain in the tumor than we get even with what we call single fraction gamma knife. But again, size is one of our big limiting factors. And the other one is the biology of the tumor. So I mentioned gliomas, and gliomas have a biology that's unlike any other kind of tumor. Gliomas are actually the most frequent kind of primary brain tumor that starts in the brain. But the gliomas are derived from normal glial cells, and these normal glial cells migrate around in the brain. So you can't cure a glioma with surgery, and you can't cure it with gamma knife either, because there are cells that have migrated away from where the tumor started out. And in fact, with most gliomas, there are cells on the other side of the brain. So even if you could take out the whole half of someone's brain where the tumor started, you still wouldn't cure it. And gamma knife, again, isn't good for that. So other kinds of radiation where you're treating the whole brain or much of the brain, and chemotherapy are often good for certain kinds of tumors. So for low-grade tumors, size is often the limiting factor. Location, interestingly, is not a limiting factor. So because the beams are coming from all around and they intersect in these spheres at the middle, but you don't have to get to the tumor from anywhere. You're getting to it from all around, as you would conceive a laser beam would work. Although lasers don't really quite work that way for the brain, because they don't go through the skull and everything. But the way that, again, you say, oh, it's like a laser beam, you just are firing in from the outside. Essentially materializes at the center.
Right. Well, so with the gliomas, it's so spread out. Basically, that's why you have to use the other radiation, because the gamma knife is very focused on one area.
Exactly.
That's
and there's another way that we think about that the gold standard for evidence in medicine is something called a randomized trial, where you've compared two different ways of doing things. And we actually have a randomized trial of stereotactic radiosurgery. It wasn't just gamma knife. Gamma knife is a brand name for the device that has the 192 beams, but there are other devices that can deliver stereotactic radiosurgery, something called a Linac scalpel. They like the name of gamma knife, so they tried to kind of take off on that, I think, as an example. But there are a lot of other devices that can do it. And so this study, people who had these gliomas were randomized, and they got standard radiation alone or standard radiation plus stereotactic radiosurgery. And it turned out the stereotactic radiosurgery was not beneficial for the group who got it, that they didn't live longer, they didn't have better quality of life. There was no real benefit to getting it.
Okay, well, because I was going to ask you about that, the main pros and cons of using the gamma knife versus actual open brain surgery. What would be because I wanted to ask you that, because I think that you were telling me about I think when you saw mine, you were saying it was almost too big to use the gamma knife.
Yeah, and sometimes we want people to know that we're right at the border of size for something, and that one of the things, a lot of tumors are growing and they're going to get bigger as time goes on. And so if we're right at the upper limit of border for size, and someone said, oh, I'm not going to do anything, I want to observe the tumor, because they're often detected, we would say, incidentally, that someone had a symptom, and then we got a scan because of the symptom, but the tumor is not even causing the symptom. It's just there, and it was lucky that we found it. And but if someone said, well, I'm going to wait until I have a symptoms, then what might happen is, well, then the tumor's too big for gamma knife, and you have to have regular surgery instead. So that size thing is an important consideration as far as the timing of doing gamma knife for some people.
Because you said there was you gave me a choice, I guess, where I could either do the open surgery versus the gamma knife, and But what are the dangers of not removing? I think you said the only thing about not removing the tumor is that you don't get to look at it and take it out. Well, what is the dangers in not removing, say, a meningioma?
Yeah,
or any type, I guess.
So there are three kinds of meningiomas, and we call them grade 1, which most meningiomas are grade 1. In the grade 1 meningiomas, you can often have a good guess from the scan because they often have calcium in them, for example. And that means they've been there a long time. It takes a long time for calcium to get deposited in a meningioma. So a fast-growing meningioma wouldn't have calcium in it as a rule. An atypical meningioma, or grade 2 meningioma, is a fast-growing one. And as many as 1 in 12 meningiomas can be atypical. You usually have a good idea whether for a given person it's likely to be atypical or not, based on how it looks on a scan, or sometimes based on having observed it over time. If you know it's growing slowly because you've gotten scans over time, then you'd say, oh, that's a grade 1 meningioma. There also are very rare malignant meningiomas or cancerous meningiomas. But again, if it doesn't look like it's growing fast, it's got calcium in it, you can say, well, that's not a cancerous meningioma, it's not a malignant one. But the gold standard for making that distinction isn't how it looks on an MRI scan, or even totally just how fast it's growing. It's actually getting it out, sectioning it, staining it, and looking at it under a microscope. A pathologist looks at it and gives you what we call a histopathologic diagnosis. So when you do Gamma Knife, you're not making an incision, you're not even drilling a little hole, so you're not getting any tissue out to find out what it is. Now, a lot of times when you look at that, the risk of surgery is higher than the risk of Gamma Knife. So the chance that it's something that there would be a benefit of knowing what it is sometimes actually smaller than the risk of surgery itself. And so that's one of the things that leads us to often recommend Gamma Knife without surgery. The other one is Gamma Knife is a pretty good treatment for atypical, for grade 2 meningiomas, and even a pretty good treatment for malignant meningiomas, although for both of those we would tend to give a little bit higher dose if we knew it were atypical or malignant. But they'll usually respond to the dose of gamma rays that we give for a grade 1, a standard meningioma.
Okay, so is it ever used in place of chemotherapy or like a pre-treatment option, the Gamma Knife? Or?
It is sometimes. So usually for metastases, and one of the things we worry about with metastases, if they're too big, so I mentioned that the risk of Gamma Knife causing complications was a function of the size of the tumor. Well, there's another thing it's actually a function of the dose. So the higher dose of radiation we give, the more likely it is to cause some sort of a side effect. Well, sometimes the tumor is so big that we're not giving a high enough dose to really get rid of the tumor. We're not able to safely give a high enough dose to get rid of the tumor. But we do give a high enough dose to kill microscopic cells that might be there. So if we did surgery first, we would potentially be leaving behind, or even worse yet, spreading microscopic cells that hadn't been treated with gamma rays. Well, if we do Gamma Knife before surgery, sometimes the tumor will shrink, although a lot of times we do it and then do surgery right away afterwards. And what that does for us is kill the microscopic cells that might be left behind. But in general, we don't use it that way very frequently, but it was a good idea that you had. You'd be a great neurosurgeon, medical scientist, I think, because you come up with a good idea. And those kind of ideas are the things that are being explored with research right now.
Right. Okay. Well, I read that that I know that you've already said this, that the meningiomas were what you treated the most, but can you in relation to other types of tumors, what are the dangers of the meningiomas? I know they have neurological side effects. They're not usually cancer, but they do have neurological side effects.
Yeah,
Right?
and so the lining around the brain is all around the brain. And so you can have a meningioma anywhere or anywhere around the brain. It can develop. It's even a little worse than that. There seem to be infoldings of those meningothelial cells, the cells that produce meningiomas and that make the lining around the brain. So you can even have a meningioma that's not on the surface of the brain. It's inside the brain itself. And that's not that rare, although most of them are on the surface of the brain. But with that combination of things, a meningioma can affect anything that the brain does. You could go blind from a meningioma. You could not be able to talk because you have a meningioma. You could get paralyzed on one side because of a meningioma. You could not be able to swallow because of a meningioma. And that gets back to the brain does so many things, and a meningioma has the potential, if untreated, to affect any of those things.
So, but it also depends on where it's located, right? Like for me, I think you said mine was where it was located affected the sight and it was my ear sight and my ears. I had noise in my ears or whatever.
Yes, and the noise in the ears is a tricky one for us because the meningioma often is changing blood flow in the brain. And when a vein gets turbulent flow in it, you can hear it because if it's near enough the ear, you'll hear it. And we call it pulsatile tinnitus, but every time your heart beats, usually if you hold your head in a certain position or do something, it'll bring it out. It doesn't necessarily happen all the time, but and anyone can get this pulsatile tinnitus, and actually it's a fairly frequent thing for people to get. We don't have any really good treatment to get rid of it. It tends to go away over time. The veins change in size, and they don't like to have turbulent flow in them, so they'll change in size to try and get rid of the turbulent flow. But some people, it can be very bothersome, that pulsatile tinnitus.
Okay. Well, I also read that the meningiomas are more predominant in women. Is that true?
It is.
Why is that? Why?
They're twice as frequent in women as they are in men. And the reason is that in women, half of the meningiomas have hormone receptors in them, and the other half don't. They're just the ones that would have occurred in a man too. The hormone receptors are estrogen and progesterone receptors. We think estrogen are the most important ones. And so in fact, meningiomas will often grow in women selectively at times when estrogen levels are high. And then at other times, sometimes they'll stop growing when estrogen levels are lower.
Okay. Well, I was wondering because I had read that it was more predominant in women. But when I was curious about this because I know when I was diagnosed with the tumor, the first thing we do is run to the internet. And I know that's got to be difficult for doctors today. How do you deal with this? Like, are there legitimate websites out there that people can use to get the right information? Or
Sure, and it's interesting. I'm kind of a proponent of the internet in some ways. That if you look at it, that people who are telling their own individual story are telling it for a reason, and sometimes it's because they had a bad experience or they have a really bad tumor, and it's become the focus of their interest. And so they're spending time creating a website about it, and so you have to realize that they're the experiences that people are reporting on the internet aren't necessarily statistically representative of what happens, but nonetheless they're valid experiences. I mean, this is that person's experience, and there's nothing wrong with them sharing it, and there's nothing wrong with someone finding out about it, and then there's nothing wrong with them asking me about it either. Because I've seen thousands and thousands of people with meningiomas, I can explain it. I can say, oh, well, that could happen. That person is relaying their experience. That was a valid experience that they had, but it's not likely to happen to you. Or I could even go beyond that and say, oh, but there's only a 1% chance something like that would happen to a given person. And so I don't think that information is bad. I do think a lot of times hospitals, our website has links to information that we've made available, but it tends not to be as personal. I mean, I do think people a lot of times like to know, well, what was your experience with this? And that's really a goal in medicine. We want your experience to have been as good as it could possibly be. And so we know some people won't get the outcome that we want. Their experience won't be as good as they wanted it to be or as we wanted it to be for them. But I don't feel like there's anything wrong with their sharing that when it happens. And sometimes we could learn from it and do better. Sometimes it was just bad luck, and we don't think there's anything we could have done that was different. But they're very valid things. And I think that when you're a super subspecialist, in a sense, that's what I would think of myself as, and say, oh, well, you're not going to come across anything on the internet that I haven't heard about. And it's not threatening to me in any way.
Right. Yeah. So you're used to, it actually can, I guess, like you said, helps you sometimes when you hear something that could possibly happen. Someone else's experience, I guess.
Absolutely.
Yeah. But the one thing that I was curious about, and it's actually pertaining to your passion of being a surgeon, is how, you spent years, in residency learning how to use your hands to perform this intricate open surgery. How has the adjustment been for you with the Gamma knife and all the new technology, or do you still get to do enough open surgery?
And so I spend more of my time on open surgery than I do on Gamma knife, and it's fairly close to half and half, but it's really nice to have both options for people. And sometimes one person is clearly better than the other, and sometimes it's a decision, it's their preference that might be driving the decision making. But so I don't feel like they compete with one another very much. The way we do the Gamma knife, there's a neurosurgeon involved, a radiation oncologist, and a medical physicist. In our case, they all have Ph.D, so they're doctors, but doctors of physics, not doctors of medicine. And we're all involved in each treatment. And the surgeon puts the halo on, or the stereotactic frame, we call it, where it's held in place with 4 things that look like ballpoint pens, as I describe it, that don't screw into the person having the procedure done, kind of a technicality, you might say. But the part that goes through the skin and rests up against the skull isn't threaded. But it does go through a threaded post on that stereotactic frame or halo. And so you could say that it looks like it's screwing in. But picture.
Can you see it?
Yeah, it's going to come into focus when you hold it really still. It comes into focus the best, I think. Yeah, but that's you can see the pin right there. That's perfect. It came into just perfect focus there, and that is what secures that frame. And then we can calculate where every point is in relation to the frame. And I'm the one who gives, I think it's the only bad part of the Gamma knife, but it's giving the 4 shots of anesthetic to numb up. And I think those shots hurt, just like any shot would.
That was that one?
Yeah, I think if you lift it up a little higher, we can see it a little bit better. Exactly. But those are where we give the shot. It raises a little welt there that you can see. And I think shots hurt. But they do a really good job of numbing it out. So I try to be as empathetic as I possibly can when I'm giving those shots, since I'm not very brave about getting them myself. And I try not to say it's going to hurt a little bit, because I've looked into it, and whenever a doctor or anyone in the hospital says it's going to be little, it just means it's not happening to the doctor. It doesn't tell them how much it's going to hurt. And so I think the shots hurt, but then they really numb it up. And then we get an MRI scan with that on, and
But this was what were you doing here with the numbers?
And so there we're making a series of measurements, and that's Mr. Rodney Rogers, who is retired from the hospital now, but who we really miss, who is one of our senior technicians who did the Gamma knife procedures with us, standing in the background. But we are making a series of measurements, and those measurements allow us to calculate the absorption of the gamma rays on the way into the target. So gamma rays aren't absorbed very much, which is the whole point of gamma rays in some ways, but they are absorbed a little bit. When you get 192 beams together, they're absorbed enough to have all these beneficial effects at the target. But they're absorbed differently by air than they are by tissue. And so we're using these numbers that we put this space helmet-like thing on, and then we make a series of measurements through it. And those measurements are used to make a model of someone's head, and then that's used to calculate the absorption of the gamma rays on the way into the target. So we're adjusting the dose to give precisely the dose that we need to give to achieve the goal of the gamma knife treatment.
And so is the brainiac mathematician, that's what your nurse called him when I was there, he's always there, the medical physicist. The medical physicist.
Yeah, and they're really a brainiac mathematician because they have a Ph.D. in physics, where they've studied for 3, 4, 5, 6 years and done research in medical physics. And they're often involved in helping develop techniques like the gamma knife or improved ways of using the gamma knife, and doing physics research to make sure that we're doing it, improving it as much as it can be improved as time goes on. But in a sense, the gamma knife is based on a whole series of calculations. It's not like open surgery where you look with your eyes or with a microscope and you're actually seeing the tumor. We see the tumor on a scan, and there's a mathematical relationship, it's just trigonometry, it turns out, between that tumor and the stereotactic frame that is not moving in relation to the tumor. And then we're using that to position the tumor at the center of the gamma ray. So it's a whole series of mathematical calculations. And the physicist and the neurosurgeon and the radiation oncologist are all triple checking to make sure at the time of the treatment that none of the assumptions behind all those mathematics are incorrect for a person on the day of the gamma knife treatment. And so we've got triple checks built in, and really more than triple checks in a lot of instances, to make sure that we're just targeting what needs to be targeted.
Okay, so that's standard procedure for him to be there for the gamma knife.
It is.
Okay. All right. Well, I know you're also, you're the co-director of the Deep Brain Stimulation Program, and all I know is that something about placing electrodes in different regions. What is that?
Yeah. So in the common thing between gamma knife and deep brain stimulation, because they do sound pretty different, but we're using images, so MRI scans usually, but sometimes it's CAT scans or sometimes just plain x-rays or something called arteriograms. We're using those to target very specific areas in the brain. And we could target and then deliver gamma rays there, or we could do a biopsy is another thing. We'll use a computer to guide a biopsy needle in to biopsy things sometimes, or to put an electrode into the brain. And then the electrode is hooked up to a pacemaker that we implant under the skin. It's all under the skin. And we then deliver electrical pulses into the brain. And in general, what those electrical pulses do is interfere with the activity. So we call it deep brain stimulation because it sounds better than deep brain messing up what that area of the brain does. But really, that's what it's doing. It's inhibiting the activity in an overactive area in the brain. And there are certain conditions that have overactive areas. Parkinson's disease is one, essential tremor is another, a condition that's fairly rare that's called dystonia is a third. Approved for deep brain stimulation under something called a humanitarian device exemption, like an orphan disease exemption or an orphan drug if it were a drug. And then it's actually approved for really bad cases of obsessive compulsive disorder too. So those are the four things in the U.S. that deep brain stimulation is approved to treat. And the most frequent treatments are Parkinson's disease and essential tremor. And it's the abnormal movements that we're treating in both of those cases. So people with Parkinson's disease might have other things like swallowing trouble, but we don't treat those, but we do treat tremor, for example, or stiffness, or trouble getting going often, freezing we call that, by inhibiting these little tiny overactive areas in the brain. The way we used to do it, as I mentioned, was with things like the gamma knife. We would just kill the overactive area. But the problem with killing it was couldn't take it back. So if you killed too much, that could cause a problem. If you killed too little, you didn't accomplish the goal that you wanted to accomplish. And to make it even trickier, the disease was changing over time. So with the deep brain stimulator, you can put these electrodes in and turn the current up or down and adjust it. So say you put one in and you caused a side effect. Well, you could turn it off, or more likely you would just adjust it so it wasn't causing that side effect anymore, but was still getting the beneficial effects that you were after. So and it was another thing that, like gamma knife, when I moved here from Boston, these things weren't available in North Carolina yet. There wasn't anyone doing deep brain stimulation here in North Carolina, or there wasn't anyone doing gamma knife when we started doing those things.
So, but it's an implant, because it said you implanted over 1,000.
Yes.
So it's something that stays in the brain.
It does.
Okay.
It's intended to be permanent, and usually they are. We just leave them in there, and it's almost, you could think of when you deliver a drug, you take it as a pill, and it kind of goes all over the body. It doesn't just go where you want it to go. Well, electricity you could make into a drug in a sense, but you wouldn't want electricity going all over your body, shocking you. But if you could deliver it just where you want it in the brain, and the targets that we're after are about the size of a pea usually, or a baby lima bean. And so the electrode is just interfering, we call it stimulating, but it's really interfering with activity in a little pea-sized area of the brain that, because of a certain disease, is actually overactive. And we're turning down the activity in that part of the brain, but we're doing it permanently, and that is because it's reversible. And so that's a nice thing. If you think about obsessive compulsive disease, you might come to mind the movie One Flew Over the Cuckoo's Nest, where they would make lesions in people's brain that could change their personality, and we've gotten away from that. But if you were going to treat obsessive compulsive disorder and you put it into the brain and someone said, well, it's changed my personality, I don't like it, you could just turn it off. But you couldn't do it with lobotomies in that movie. But the deep brain stimulators are, again, reversible, is one of the big advantages, or adjustable is really probably the more frequent advantage.
Right. So, but it sounds like you still do about an equal amount of open surgery versus the gamma knife and the other procedures. You still get to do the open surgery, which was
exactly.
Yeah. So yeah. Well, and I've just got a couple more questions, and I will wrap it up. I was curious as to what do you foresee in the future, like in terms of new technology or new brain surgery procedures? Is there anything?
There is. So one of the exciting things that we're doing now is some tumors like these gliomas that we talked about don't respond to gamma knife, but we need better treatments for them. If they're right on the surface, we'd go in and do surgery and take it out, and then it'd be followed by radiation chemotherapy. But say one were deeper in the brain where you had to go through something important to get to it, to take it out. So a way that we're treating those now is with a laser. This time it really is a laser, but lasers can be delivered through little fiber optic fibers. And so we can drill a hole and put a fiber optic fiber into the brain and deliver a laser with it. Well, the thing that was limiting that before is you couldn't really see in the brain. It's not like could do a laparoscopic procedure in the abdomen where you blow the abdomen up with nitrogen gas and then you can see around in there, but you can't really do that to the skull. And so just putting the laser in didn't help unless you could see what you were doing. So the big technological advance is being able to program an MRI scanner to measure temperature in the brain. So then we put the laser in and we're heating areas. The laser has a mirror in it, so it fires to the side. And then we're using the laser to heat areas in the brain. We can move, there's a robot that's in the MRI scanner with us. It's moving the laser and changing the direction that it's firing in. So we can heat and kill an area. It's not as precise as the Gamma knife, but for things where the Gamma knife doesn't work, it's a really good option. It's called laser interstitial thermal therapy, or that's one of the generic names for it. That would be like stereotactic radiosurgery. So that's a really exciting thing. Another one are these viruses that we're putting into the brain. So we did a study for Parkinson's disease where we used a virus to introduce a gene into an overactive area in the brain. And the gene didn't kill the cells, didn't inactivate them even, but it changed them. So they were producing a neurotransmitter called glutamate that excited other cells, an excitatory neurotransmitter. Well, this gene chopped a carboxy group off of the glutamate and made it something called GABA, gamma aminobutyric acid. It's an inhibitory neurotransmitter. So we changed these overactive excitatory cells to now made them more overactive inhibitory cells and reverse some of the effects of Parkinson's disease by putting a gene into someone's brain. But just imagine if someone had a deficiency, they were maybe born without an important gene in their brain, that we're at the stage now where we could put a new gene in and potentially treat that disease and fix something. And right now, the way we're delivering those genes is by using viruses, is what we call vectors. So there are a lot of exciting things going on in medicine in general, and certainly I'm enthusiastic about those that are in neurosurgery.
No, that's exciting. So you're actually doing these now.
That's right. And there are things. So this laser interstitial thermal therapy is already approved by the U.S. Food and Drug Administration, so we can do that routinely. None of these virus treatments are approved. They're all considered to be experimental still.
Is there anything that they can do for the Alzheimer's? But that's not.
Yeah, no, I think there's a lot of really good research going on there. Of course, I'm interested in the neurosurgical aspects of it and delivering things into the brain. So one of the things that you might want to deliver would be, say, an antibody to amyloid. And there are studies going on now with antibodies being delivered systemically. Some of those, a little bit of them gets into the brain, but you might work even better if we delivered it directly into the brain. Or another idea that I'm very enthusiastic about is delivering something called neurotrophic factors into the brain. Factors that would protect the neurons in the brain from dying, and that would also make the neurons that are left behind when someone's starting to get Alzheimer's disease work better, that can reverse some of the symptoms. And there are a lot of technological things there that haven't been solved yet. And right now, we're not doing any clinical trials with those things. But I'm optimistic that there will be trials like that, and still in my career, I hope.
Yeah, well, that would be great. That would be exciting, because I hear more and more about people with Alzheimer's, and
there are trials of deep brain stimulation for Alzheimer's, interestingly, that are going on. Not to the best of my knowledge, widely yet, but at a few centers in Canada and elsewhere. And in that case, they're really trying to stimulate rather than they're not trying to inhibit an overactive area. They're actually trying to make an area that's involved in generating memories more active. And one of the targets is an area called the fornices that generate memories. And if you stimulate them in just the right way, you can sometimes make people's memory much better. And there are some really interesting things like that going on, where you could implant electrodes that are really stimulating rather than interfering with activity.
Wow, that's great though that they've got all those trials going on. That's That's one thing that always concerns me is hearing about people who have Alzheimer's.
It is, and there's no shortage. If any of your listeners want to get involved in doing research, or you can support research in all sorts of different ways by, for example, interviewing Neurosurgeon on your broadcast, on your show. That's a great way of supporting research, because it gets people, makes people more knowledgeable about it, allows them to become more knowledgeable about it. And then I think that sometimes people think, oh, science, it's boring. And unless you have Alzheimer's disease and the research is about Alzheimer's, it can be kind of boring. But if you find someone who that's their passion through something like this, anyone, you don't have to be a brainiac physicist to make a difference. That you can really make a difference in a lot of different ways to contributing to research, for example.
Well, before we close up, what are some of the things that people could do to contribute, just so they'll know?
Well, one of the big things we always want are for people to donate money, of course. But and there are some people who are in a position to do that and who are very passionate. Another thing that we have all the time, and they're usually students who come through, but it doesn't have to be a student. But they say, oh, is there a project that I could help you with? It's interesting, where I got my Ph.D., I worked in a lab, and the first person to work in that lab was also the first person to win the Nobel Prize in Medicine in the United States. His name was Alexis Carrel. There are a lot of interesting things about Alexis Carrel, but Charles Lindbergh volunteered to work with him and worked in the exact lab that I worked in. There was a staircase that he made. And Lindbergh made a heart-lung machine, about the first really perfusion machine that could be used to keep organs alive outside of the body, essentially. And that's, an example. He wasn't a doctor. He wasn't, he had a lot of skill, but he was able to use that. Students will often work on a project where we would get permission from our institutional review board to go back and look up medical records, for example, and then they get anonymized. We take the patient's name out of the record to protect their privacy, which is something that's very important to us. Then we would look at the results, say, of all the people who we've treated who had meningiomas, and then look at different variables that are predicting size, maybe calcium in the meningioma, things like that would predict, oh, this person maybe was more likely to get a side effect and so should have surgery, regular surgery, instead of gamma knife surgery. And this person no one who had a tumor that fit these criteria had a side effect. So gamma knife would be a better option for that person. And a student will often come in and spend a summer doing something like that, where they look all this up and they're working with us. Although they often find I'm so busy that they're doing all the work and they're getting advice from me, really. But so in the end, someone could come in and really do a project like that. They have to get training and agree to follow all the rules about confidentiality if they want to do something like that. But someone else, their passion might be in public relations, in just helping us get the word out about some of the things that we're doing. And that's equally important in a lot of ways. So it's not all about being able to donate lots of money. There are a lot of ways that people could contribute if that's a passion for them. And then even someone who's donating money, we're asking, we want it to be something where they feel like they're getting their money's worth out of it. They're saying, oh yeah, no, I'm investing in this. This is something that we're doing together to make the world a better place. Not, oh, I'm giving this money to Dr. Tatter, I hope he uses it for something good. Sometimes people do that, which we very much appreciate if someone just out of gratitude does something like that. But what we really get enthusiastic about is when we find something that we're both passionate about. And again, there are a lot of ways, and you're the greatest example of one just right now.
Well, great. Well, so if someone wants to help in any way, would they just contact Wake Forest, the the medical center, or?
Yeah, and I think a lot of times there'd be a specific that, you know, if someone has a specific idea that they want to do, you know, they could just call my office, and Diana Hale is my great assistant, and she'd say, oh, well, here's what we need to do. You know, I'm going to get you to talk to this person, or, you know, I'm going to ask Dr. Tatter about it, or and that working together as a team definitely applies to research, just like it does to taking care of people.
Okay, great. Well, I'll have a replay of this in my blog, and then I'll get all the information. Anything that you want me to have in there, I'll have in there as well.
Yeah,
so.
It's great. It's searchable, so you know when you type Stephen Tatter into the a web search engine, this will come up, and then someone might come back. A student might come back and look at it and say, "Oh, you know, I want to do research and help solve some of these problems that you've brought up."
Yeah, so that'll be great. Well, I have one last question, and then I'll end it. Is there any advice you would give to someone, a young person who aspires to become a doctor or a surgeon like you, who wants to become successful? Is there any?
Oh, there's lots of advice. I think that one of the things that I think is important is to enjoy what you're doing as you're doing it. That you can make it if you say, "Oh, I want to be a neurosurgeon, but I don't want to go to college, and I don't want to go to medical school, and I don't want to do a residency, but I do want to be a neurosurgeon." You can make it. But you know, college is 4 years, medical school is 4 years, a neurosurgery residency is 7 years. So it's a lot of time to spend not doing something you enjoy. But if you enjoy studying things that can help you get into medical school and eventually contribute to the advancement of medical science and taking care of people, and then you enjoy medical school because you're learning about science and you're learning things. And then you enjoy residency because you're getting to actually finally help people directly, and you're learning at the same time. That makes it the easiest. A lot of times I think that medical schools and residencies are looking for specific things. And one of the big things is the thing that we've just been talking about is people who are interested in advancing the field and doing research. And so if someone says, "Oh, you know, I really like the idea of helping learn more about how the best way to do gamma knife, or who the best candidates for gamma knife is, or learning more about how to deliver viruses in the brain to treat Alzheimer's disease," you know, that's something I could get really enthusiastic about. Then that I would say looks really good to the committees that are evaluating people for getting into medical school and doing residency. But you can do it for two reasons: one, to look good, which doesn't hurt, but the other one is because you really have found something that you're passionate about.
Yeah, well, that's great advice. Well, I'm going to have all that for everything in the blog that I'll put the replay of this in, and so that way that when someone sees it, they'll know how to, you know, get in touch with you, and I'll get with you on that. So don't hang up yet, Dr. Tatter. I'm just going to say goodbye to the viewers, and then I'll take us off air. But I wanted to thank you so much for being here today, Dr. Tatter. Because I know you're busy, and I hate to end this. I could just question you all night, but it's been such an honor and a pleasure to interview you. You're such a rock star to me. So
you've put up with a lot of my explanations, and if the medical students would be falling asleep during some of those long-winded lectures that I tend to give. But thank you for having me. It's really been fun doing it, and thanks for making it available, because I think it's going to help a lot of people to be able to hear about some of these things.
Yeah, I do too. So I'm looking forward to getting it in the blog and everything. So thanks so much. Don't hang up yet, though. I want to thank the viewers for their continued support, and join me again. In a couple weeks, I'm actually going to have an Oriental rock guitarist, Yossi Sassi, from Jerusalem. He's excellent guitarist on my show. So stay tuned for that, and stay tuned to Tamarah's Closet. And I'll have the replay of Dr. Tatter, the interview here with him today, in my blog as well at tamarahscloset.com. So thanks again, and I will see you next time. Thanks.